Ladies and gentlemen, good morning. We're now starting today's lectures, and we will have 4 lectures this morning combined. The first part of the lecture will look at the concept of intraocular pressure. Intraocular pressure can be normal, or it can be elevated, and in some cases the pressure can go low. It's from that concept the idea of a high pressure in the eye or a low pressure in the eye is derived. So look firstly at the intraocular pressure and the concept of glaucoma. Then after that, we'll look at the primary types of glaucomas. We've got primary angle closure glaucoma, primary congenital glaucoma, primary open angle glaucoma. So the primary glaucomas are all a good number, 3 of them here, before you talk of the secondary glaucoma. So for today, we'll just look at the intraocular pressure and the concept of glaucoma. Then we'll go on to look at the three types of glaucomas: the angle closure, the congenital glaucoma, and the open angle glaucoma. Problem here. Ocular pressure is determined by the balance between the rate of aqueous secretion and the aqueous outflow. If the rate is high, more aqueous is being secreted and the outflow is lower, you're going to have a high pressure. Similarly, if you've got aqueous secretion which is normal, but the outflow is not normal, it's not a lot of aqueous is going out, eventually you have a buildup of pressure in the eye. So ocular pressure is actually determined by this balance, the inflow and outflow of aqueous from the eye. Outflow is related to the resistance encountered in the outflow channels and into the levels of sclerovenous pressure. What is that? When the aqueous is in the eye, there is an outflow channel. If there is a resistance in those channels, if those channels are blocked, naturally, despite having normal production of aqueous, you're now going to have a buildup of pressure in the eye. Concept of normal intraocular pressure. The distribution of intraocular pressure within the general population has a range of 11 to 21 millimeters of mercury. So a normal intraocular pressure in an eye is not a single figure. You can see there is a range there. Someone may come with 11, 12, it's normal. They may come with up to 20, it's normal. The question is, when they are getting to 20, do they have other symptoms suggesting of glaucoma? That's when you can say, okay, it's in the upper range, but I think this is a case of glaucoma. So there is a range, 11 to 21. There is no absolute pathological point in the pressure. There's a range. You will find some people even at 15, 12, 15, they are exhibiting signs of high pressure, but it's only 15. How? It's a range. For individuals, it varies. 21 millimeters mercury is considered as the upper limit of normal. So pressures above 21 millimeters are viewed with suspicion. By suspicion, you are now contemplating that this is a patient of glaucoma. This is a high pressure. The other thing is ocular pressure is also determined by the balance between the rate of aqueous secretion and the I think so. This is the one supposed to come. Let's go a bit forward. In some patients, glaucomatous damage occurs with intraocular pressures less than 21. You remember I said 21 is the upper limit. But in some patients, even with pressures below that upper limit, you find they are also showing signs of glaucoma. Those types of patients, you say they've got normal tension glaucoma because their pressures appear to be within the normal, but with that normal pressure, they are also showing signs of a glaucoma, of a raised intraocular pressure, although their pressure is within the normal. So that type of glaucoma is what we refer to as the normal tension glaucoma or normal pressure glaucoma. So glaucoma, raised intraocular pressure, you can have one with normal with a patient having normal pressure. You can have one with a patient having higher than the expected normal. Okay. Other patients remain unaffected with pressures up to 30 millimeters of mercury. Those type of patients, you refer to them as having ocular hypertension. The pressures are high. There are no clinical signs suggesting they have glaucoma, but it's higher than the expected normal. So those are the ones they refer to as ocular hypertension. Intraocular pressure variations, time of the day. Intraocular pressure varies with the time of the day. You have a diurnal pattern which varies with a tendency to be high in the mornings and lower in the afternoon or evening. Normal eyes have a mean diurnal pressure variation of 5 millimeters. In other words, you can have that variation of 5 millimeters with those that are within the norm. Ocular hypertensives and glaucomatous eyes exhibit a wider variation. Okay. Phasing concept. When you're talking about glaucoma, you come across that phasing. Phasing concept is the taking of intraocular pressure at different times of the day. And it will help to determine if we're dealing with a glaucoma case. Remember, I'm saying within the day, there are those variations. So when we say phasing, we'll take a pressure in the morning, maybe at 6 or 7, you take at 9, you take at 12. You look at the end of the day whether they are spiking in terms of pressure at some place within the same day. If you see the patient in the morning, they may have what is basically known as normal. You leave them. Come on,
why can't you rewatch it? I can't rewatch. I see someone record. Look at what I'm watching. Oh. What's wrong? Charlie. Unless if I press where I can speak. You say body.
Hi.
What's some baba? Well, explain that.
Yes, it just gives you the concept that I think the pressure is high or it's within normal. And you need to have a lot of experience because you're now thinking from your brain, not from the reality on the clinical aspect of the patient. Yes, you can feel it's hard. Pressure seems to be high. It's a fair statement, but you cannot attach a figure of how high it is until you've got a proper machine. You know. This is going backward, you know. Applanation tonometry is based on this principle of Imbert-Fick principle, which says the pressure inside an ideal dry-walled sphere equals the force necessary to flatten its surface divided by the area of flattening. Okay? This is the principle we use for applanation. You will touch the eyeball with a probe, you flatten it, and the pressure will equal to the force, you know. Pressure is equal to force divided by the area. The force you use to flatten and the area you flattened, when you divide like that, it gives you the pressure in that eye. That's the principle for this tonometer. and is commonly used in the clinic everywhere. Okay. And this is the tonometer. This probe goes onto the eye to flatten a bit of that cornea. So the force used to flatten the area is the area divided by the force, gives you the pressure. That's how the reading comes out there. And when you do applanation tonometry, you first put a bit of fluorescein, and it gives you these semicircle rings. Because within this probe, it has got two semispheres. They divide that circle of fluorescein into half. When you align them like that, that's the end point for your reading. You will start from there. The idea is to align the inner edge of the lower semicircle and the upper edge of the upper semicircle like that. That's the end point for you to now get the reading of the pressure. I know it looks complicated, but it's a straightforward issue here. And everyone, whether you're optometrist, ophthalmologist, ophthalmic clinical, this you should learn. This you should learn. It's more objective than palpating and say, no, the pressure seems to be high. Okay, yeah, seems to be high, but how high? You don't know. This one gives you a specific number. So many millimeters of mercury pressure. So next time it's below that figure, you will know there is improvement. Or when it goes above that figure, you will know you're not achieving anything from your intervention. So this everyone must learn how to use it. And we'll try to teach you in the clinic. Most eye centers, they've got this. Most eye hospitals, they've got all this. You should have. This is better palpation. Palpation only helps you to tell you the pressure feels. You don't know the figure you can attach to it. But you want actual figures to be attached there. So in applanation tonometry, the cornea is flattened and the intraocular pressure is determined by measuring the applanating force for flattening that force you are using to flatten the cornea, applanating force and the area which has been flattened. You know? A Goldman tonometer measures the force necessary to flatten an area of the cornea of 3.06 millimeters diameter. At this diameter, the resistance of the cornea to flattening is counterbalanced by the capillary attraction of the tear meniscus for the tonometer. Then at that, because it now counterbalances, that at that point, you can have a reading of the pressure, a genuine reading. Furthermore, intraocular pressure in millimeters of mercury equals the flattening force in grams multiplied by 10. So if you want to be specific, scientific, really, this in the eye clinic. Palpating with fingers and feeding the eyeball a bit hard, no, the pressure is high. Yes, the pressure is high. You are not telling a lie, but you can't attach a specific number. Yes, we have. You can't attach a specific number until you use a tonometer specifically meant to measure the pressure. it gives you the split image as I showed you. It's the inner side touching the upper half and the lower half, the inner side of the circle. In this one and that one, they touch. Once they touch, that's the end point at which you read the pressure. So a split image device allows the examiner to determine the flattened area with great accuracy. Fluorescein in the tear film is used to outline the area of flattening. End point is reached when the inner edges of the semicircles, the lower one and the upper one, the inner edges, once they touch, that's the end point, then you take the reading at that point. What are the advantages of applanation tonometry? Accuracy. What? Reducing circumstances. Autonomy, this obviously the accuracy is reduced in the following circumstances where there is corneal edema. Because corneal edema, you will see that there is ballooning up of the epithelial part of the cells. So you have to go deeper through that edematous area before you, so that way you will not have a very good reading. You know, intraocular pressure taken over a cornea scar also is not reliable. It has to be taken over normal. If you take it over the cornea scar, it leads to false high readings because there is a scar there. And if there is a lot of edema, you also have wrong reading. Once we we've looked at the pressures, now we can classify the glaucomas. Primary glaucomas. There's primary open angle glaucoma, popularly known as POAG, normal tension glaucoma, primary angle closure glaucoma, and primary congenital glaucomas. These are the primary glaucomas you get. We'll go through them.
So normal tension, in other words, an open angle.
Yes, normal tension means the pressures of the eyeball are within the normal range. But despite being within the normal range, the patient is exhibiting signs of glaucoma. For example, they may have a cupped disc, which you normally find in those that have high pressures. This one has a cupped disc. This one has got a visual losses, but the pressures is within the normal. So, apart from, you know, you do the readings, but you must find out, is there damage consistent with glaucoma there? For example, I come with high readings, pressure readings, but I don't show any form of damage due to glaucoma on the eye. Those are the ocular hypertensives. The same person, another person comes with high pressures and they show you cupped discs. You will know this one is not a normal tension glaucoma. This one is a primary open angle glaucoma, because the angle is also open. When they say the angle, we're talking of the drainage angle, out where the fluid is drained out of the eye. Others who have high pressures, drainage poor, those are the closure, angle closure. The drainage angle is closed. Pressures keep rising, and there will be disc cupping. Okay. We'll look at these glaucomas for today and see how far we go. Here we go. Those were primary glaucomas. There are also secondary glaucomas, secondary open angle glaucoma, secondary angle closure glaucoma, pseudoexfoliation syndrome, pigment dispersion syndrome, and neovascular glaucoma. In other words, these are glaucomas arising from some other event. There is a cause. A primary one, there is no cause why the patient has got that, but you just find they've got high pressure. In a secondary, there is a cause, which you can see. Okay.
For instance, there is uveitis now, and that or chronic uveitis, then you find that.
The angle closes up.
Okay.
Yes. That's a secondary glaucoma. Secondary to the presence of this severe uveitis. Other glaucomas can be lens-related glaucoma. These are secondary glaucomas, lens-related. You have, for example, dislocation of the lens into the anterior chamber, because the lens is behind the iris, isn't it? If it comes into the anterior chamber, may block the outflow, may interfere with the outflow of the aqueous. Production is from the posterior through the pupil, outflow is in the anterior chamber, the angle. So if there is a lens there, there is blockage, yes, there is blockage, and it leads to a higher pressure. That's a secondary glaucoma. So lens-related glaucomas, phacolytic glaucomas, phacomorphic glaucomas, lens dislocation into the anterior chamber, the one I'm talking about. Traumatic glaucomas also are sometimes they are not. Sometimes they are usually lens-related. A case of hyphema. What is hyphema? Presence of blood in the anterior chamber, blocking the outflow channels, leading to the rise of pressure. That is a secondary glaucoma. Usually following trauma from fighting. Those great people want to fight every day, or maybe something has hit the eye accidentally. They have now this bleeding into the eye. The cells go and settle into the outflow channels, and the pressure starts building up. That's a secondary glaucoma. That's what we call traumatic glaucomas, hyphema. And angle recession can lead to glaucoma. Glaucoma in intraocular tumors. If you have intraocular tumors, pressing or some tumor cells coming up into the anterior chamber and blocking the angle, you are going to have raised pressure. Those are secondary to the tumor.
Sir,
Yes.
what's the relationship between glaucoma and the tumors, whereby there's also raised ocular pressure, but okay, the eye is big. Because there was a slide which I was reading.
Sorry, I'm sure your friends would like to hear what you're saying.
Yes.
Yeah.
What's the relationship between glaucoma and the tumors?
Mm-hmm.
Yes. Because I was studying on the same
Topic.
Mm-hmm. The science, all the science which was there was for glaucoma. Everything was talking about glaucoma.
What is ophthalmos? Since you were studying, what did you read?
It's actually the enlargement of the eye.
Mm-hmm.
Yes. Due to increase intraocular pressure.
The increase is coming from where? Reduced outflow or reduced or increased production?
Probably, I was thinking that it's actually a congenital.
It's a congenital thing.
Yes.
But this one, which we are talking about, is not congenital. It's not congenital at all. Congenital means as the child is being born, they've got this disease. But these, the glaucomas we're talking about, things like traumatic glaucomas, These were people who were born nicely, maybe a bit naughty, children playing with friends, they get hammered on the eye and there is bleeding. Not necessarily a boy, there are even adults who are fighting over beer, over girlfriends, over boyfriends, like that. They fight, you can end up having a traumatic glaucoma.
So there is a relationship between glaucoma and glaucoma.
Yes, slight relationship. Here, you cannot say this is Bothamus when there is a specific cause here. Okay. Tumors, epithelial ingrowth. What is epithelial ingrowth? You have epithelial cells, for example, you do some surgery, you have epithelium on the cornea. It grows in through a gap in the incision which you made. Then it goes and grows into the anterior angle, closing up the outflow channels. That's epithelial ingrowth, what I talk about. Epithelial cells growing into the angle. Let's go to primary open angle glaucoma, POAG. It's also called chronic simple glaucoma. This is one of the commonest glaucomas around in the clinics, everywhere. The features of primary open angle glaucoma are that the pressure, intraocular pressure, is greater than 21 millimeters of mercury at some stage. Okay? At some stage. Why am I saying at some stage? You will examine this patient today, you find the pressures are within normal. But when you look at the disc, they are showing you signs of having glaucoma, capped disc. You know? The other day you come, so in the early stages, it's not consistently present. That's why they say intraocular pressure greater than 21 millimeters of mercury at some stage. This is in the early stages, really. Once you go to an advanced stage, the pressures will always, they will find them very high unless you control them by treatment. And if you don't control, ultimately it will be a blind eye. Glaucomatous optic nerve damage. How can you tell that the optic nerve is damaged? There is a capping of the optic disc. Because of the pressures, for example, you find like a cap, pressure, because of the pressure coming that way. This is it, capped. Looking for? Huh? Oh, the other side, yeah. So you have glaucomatous optic nerve damage. You have an open anterior chamber angle. And therefore, if there is pressure, you check there is an open anterior chamber. It can't be a closed angle glaucoma, angle closure glaucoma. So for you to arrive at a diagnosis of primary open angle, the angle must be open, the pressure is higher than 21, and it may show you characteristic visual field defects related to the damage on the disc. Apart from that, there will be absence of signs of secondary glaucoma. And lastly, insidious onset. Insidious onset. What is insidious onset? What is insidious onset? You find it in textbook, insidious onset, insidious. There's no drama. It comes in slowly, slowly. Yes, but the patient will not be aware that they've got this disease. If the disease starts with a slap, you will know when I was slapped, that's when my eye stopped seeing. But in this, you are slowly losing eyesight sight without knowing. That's what is called the insidious onset. The features are there, pressure is rising, and the pressure rise leads to the glaucomatous optic nerve damage, an open anterior chamber. If it's an open anterior chamber, it's not a closed angle glaucoma. It's an open angle glaucoma, you know. The visual fields characteristic to glaucoma and the absence of any signs suggesting secondary glaucoma. Insidious onset, quietly coming in. There is no drama to it that, after the injury, that's when I stopped seeing. It means there was something which triggered the loss of sight. But in this, there is nothing the patient can, they don't remember of anything that could have triggered the loss of sight. Note, primary open angle glaucoma is the most prevalent type of glaucoma and affects both sexes equally. It's the commonest glaucoma. When they say prevalent, it's the commonest type of glaucoma which you see. Affects both males and females equally, Risk factors, the higher the intraocular pressure, the greater the likelihood of glaucoma. Age, more common in older individuals, like me. But I don't have glaucoma. I'm old, but I don't have glaucoma. So very unlikely that you can have, a 10-year boy here at a primary open angle glaucoma. Such boys normally are talking of some congenital elements, which maybe you should thoroughly look around. What is the cause? It could have been there from childhood. The rest, this glaucoma is significantly more common in the black individuals than whites. In Africans like you and me, black individuals. Okay, on here than in the other side of the world. Difficult moving. Is this a continuation? Mm-hmm. Okay. Family history of glaucoma, you normally find it there. There's the first degree relatives of patients of primary open are at increased risk. Who are the first degree relatives?
Your siblings.
See?
Siblings.
Yeah. Siblings.
Yeah. Parents.
Your brothers and sisters, you are born from the same family. You, if you have glaucoma, those are also most likely affected. Okay. That's the first degree relatives. The ones you are born with. The ones you normally fight with until you stop fighting when you grow. Siblings are 4 times at risk. Brothers and sisters, you see? Offspring, 2 times at risk than the normal population. Offspring is the child you produce, I produce, is my offspring. If I have glaucoma, my offspring is twice as common to get the glaucoma. But my brothers and sisters, who I was born with in the same family, they've got 4 times the chance of getting glaucoma. Okay, so siblings 4 times at risk, offspring, who are the children, 2 times as risk than the normal population. Diabetes mellitus has increased the incidence of primary open-angle glaucoma. Myopia, short-sightedness, has increased the incidence of primary open-angle glaucoma. Those who are short-sighted, most likely a good number of them likely to have primary open-angle glaucoma. Vascular diseases like systemic hypertension, branch retinal vein occlusion, and migraine, they've increased the incidence of primary open-angle glaucoma. Like you grow, no, I've got BP. The same person who has BP, when you're examining, you're normally looking at has he got any intraocular bleed, on the retina. But also, please check the pressure. These are the same patients who are at increased risk of getting even the glaucoma. Hypertensives, vascular disease, systemic hypertension, branch retinal vein occlusion, and migraine, they have an increased incidence of primary open-angle glaucoma. So if they have hypertension, they are also in that group. Genetics, mutations in chromosome 1q21 up to q31 are associated with primary open-angle glaucoma. This gene codes for the glycoprotein myosin, which is found in the trabecular meshwork to block the outflow channels. Steroid responsiveness, proportion of the population develops an elevation of intraocular pressure in a response to a course of topical steroids. So you hear, if you take a lot of steroids, you have your pressure raised. It's not everyone, but a good proportion of them do have that. It's also referred to as steroid responsiveness. As they take steroids, you find their pressure is rising.
Yeah. Yeah. Yeah.
Is that it?
No, we can continue.
We can continue. So systemic steroids are much less prone to cause elevation of intraocular pressure, but price mechanisms of the steroid response is uncertain, but may be mediated by an increase in trabecular meshwork cell myosin production. These are theories to try and explain why there is this problem of raised intraocular pressure. Whatever it is, once you discover that this patient has got a raised intraocular pressure, treat as glaucoma. Apart from the raised intraocular pressure, do they have signs consistent with glaucoma? Is the cupped disc enlarged? Is it, cupping or what they call cupping of the optic disc? Is it cupped or not?
How do you know in terms of cutting of this, like the range, the normal range and the abnormal range?
Normal, I think up to 0.05, half the disc. But above that, once you go to over half, 6, 7, 8.7, 0.8, it means the capping is more. Normal range is some people up to 5 only, halfway. They'll have a small disc like that. But once you have a disc, this is the disc, so it will be like that. This is the disc, this is the cap. But once it comes towards there, it means it's more capped. There is only a small rim between the cap and the edge of the optic disc. You need to see patients, then you appreciate what a cupped disc is. And once you have seen one, you will never miss it. It's one of the easiest things to. Pathogenesis of glaucomatous optic neuropathy. Mechanisms involved: direct mechanical damage to the retinal nerve fibers at the optic nerve head. Then you have ischemic damage, possibly due to compression of the blood vessels supplying the optic nerve head. It's the pressure inside, and the disc, the center of the disc, is the weaker point. So as more pressure builds up, it's pushing there to make a cup. Okay. And once you look, you get to appreciate what a cup, a normal cup looks like. An abnormal one, it means it's bigger than the normal. You know? Then you know there's a problem of glaucoma here. You check the pressures as well. What you're seeing there must be consistent with the actual readings. If they're not consistent, you are seeing maybe some inherited stuff. There you are. Here's a picture. The optic disc is up to there, the outer ring. This is the cup. Vessels are pushed on the sides. This is supposed to be deepened. This is the weaker part. Like that. This is the optic cup. This is the disc margin. This is the neuroretinal rim. With more capping, then the neuroretinal rim becomes thinner because the cap is now expanding. This, as more capping occurs, it's getting towards the edge of the rim. These are vessels you can't see where you can't see the base of the cap because the picture is focused on the top part there. Okay. Did I miss one? So that's the capping. The disc margin is out there. Vessels in the cap are not seen because they are at a lower level than where the picture is taken. You focus on the vessels in the cap. These vessels out there will be blurred. These vessels, if you focus on what is in the disc, these vessels will be blurred. Okay. The damage is via both mechanisms, might lead to reduction in axoplasm. What is this? There's a picture, there's a slide missing there. Damage, damage via both no, this is again something missing behind. No, forward a bit. Here, forward. Damage via both mechanisms might lead to reduction in axoplasmic flow. Interference with the delivery of nutrients, removal of metabolic products, deprivation. But where the mechanisms, there must be another slide we've missed. Direct mechanical damage, mechanisms involved. Direct mechanical damage to the retinal nerve fibers at the optic nerve head. And then ischemic damage possibly due to compression. Once there's compression, the blood vessels supplying the optic nerve head are affected, and there is insufficiency. So this is the mechanisms which leads to the optic disc capping. A direct mechanical damage because of the pressure rise. And secondly, an ischemic damage, as you compress there is ischemia. Nutrients are not going comfortably there because you've compressed the blood vessels or supplying the optic nerve head. So these two is what leads to optic disc cupping, direct compression and ischemic damage. Then we can go to the next one. So damage via both mechanisms must lead to reduction in axoplasmic flow, interference with the delivery of nutrients and removal of metabolic products, and deprivation of neuronal growth factors and the oxidative injury to the tissues. Initiation of immune-mediated damage. I think the top ones are the main issues. It's mechanical, and if you compress, some of the nutrients won't reach there, and therefore the tissues there are damaged. Primary open angle glaucoma diagnosis, initial evaluation of a case. This is very, very important for you people to understand, because this is where diagnosis begins, to understand the history of the patient. Visual symptoms will usually be absent. If a patient comes, you will find that they are able to see, but not comfortable. You know, visual symptoms will usually be absent unless damage is advanced. In the initial stages, the patient will look quite normal and happy, like you and me. Previous ophthalmic history specifically ask about refractive errors. Myopia carries an increased risk of primary open angle glaucoma. What are you? Myopic? Don't worry. You're not dying today. I'm myopic, I'm not dying today. I'm still around. So don't worry out there, those of you who are myopic. But myopia tends to be associated with this. Refractive errors, myopia carries a higher increased risk of primary open angle glaucoma. Hypermetropia is common in primary angle closure. Okay. Long-sightedness, more common in primary angle closure glaucoma, while short-sightedness more common in the primary open angle glaucoma. Okay. Possible causes of secondary glaucomas, e.g., ocular trauma, inflammations, and primary eye surgery could be the cause. So when you are doing the initial diagnosis, you always ask, what is your problem? The patient will tell you. Once they start telling you their history, this is where we make a lot of mistakes as clinicians, unless you are nicely taught. A patient is busy explaining it. No, don't worry, it's a small issue. It's a small issue. It's no small issue. That's how that patient has come to the hospital. Give the patient a chance to explain. Okay? You're better off you spend a few more minutes than cutting him off. Especially elderly people, they get scared. Doctor, they've not achieved anything. Any evaluation of a case, give the patient the chance to explain. I prefer to see 10 patients very well than 20 patients haphazard. But the 20 will still come. They'll still come back. So let's take proper history, specifically ask about it, refractive errors, and the association, myopia to open angle, hypermetropia to the other one to closed angle glaucoma. Okay. Apart from that, ask about trauma, Was the patient punched? Was it after a fight? Was it after an accident? Any signs of previous eye disease, previous eye surgery? Once you get all those facts nicely, if you take a good history, you have an idea where you are going to go with the patient. The worst part of clinical medicine I've seen is a patient is explaining, "Hapana no sana po, twala solve. No. Person has moved all the way from home to come to you at Panon. That's why he came. Give that patient chance to say what is their problem, to say how it started, and they'll be very happy. A lot of patients, they want they've come all the way to come and give you their problems. Now you are busy entangling, cutting them through. They will not be happy. And in history taking, you don't suggest. No, that's not the way you take history. You are now suggesting. For an old person, you have misled yourself from your picture. Let the patient himself say it, then you'll be on safe ground. Don't be suggesting, don't keep on suggesting what it should be. Let the patient say what it is that they are experiencing. Then you will get the correct picture of the patient's history. A lot of people make such mistakes, and in the end, they fail to make correct diagnosis. Because patients, they come you are the be it and end all of everything. They have faith in you. So when you start suggesting this and this and this, doctor okay, let's go to the real picture. But it's a very serious issue which a lot of people make. We should never make such things. Family history, ask about primary open-angle glaucoma or related conditions such as ocular hypertension. In some families, there are people well educated. They know that they've got this type of disease. A relative will come, they will say, yeah, my uncle has got this, my dad has got, my brother has got this. Okay. Other ocular diseases in the family members, you are getting the history there. These family members were talking of brothers and sisters, mother and father. Yeah? Not the uncles, no, not those. Close relatives. Ask about the past medical history. Ask about asthma, heart failure, heart block, peripheral vascular disease, head injury, stroke, and intracranial pathology. Were you involved in an accident or something like that? Diabetes, sugar disease. I think a lot of people do understand sugar disease these days. Diabetes has increased the risk of primary open-angle glaucoma and systemic hypertension. Diabetes increased the risk of primary open-angle glaucoma. I'm diabetic, but I still don't have. I'm not yet a glaucoma patient. Systemic hypertension has increased the risk of some people coming.
I think he wanted to say something.
To say something. Who? Me?
Someone.
Yeah, let them say. Before I proceed, let them say. Who is this one? Who wanted to say something?
Oh, yeah.
Oh, Pule Mungi. Pule. Pule, are you there? Very into unmute. Family history. Ask about primary open angle glaucoma within the family or related conditions such as ocular hypertension. Ask about other ocular diseases in the family. Past medical history. Ask about asthma, heart failure, heart block, head injury, stroke, intracranial pathology. Diabetes mellitus has an increased risk of primary open angle glaucoma. Systemic hypertension is an increased risk of primary open angle glaucoma. Dr. Mumba has got both, but I don't have glaucoma. Somehow, thank God. Yes. Well controlled. Current medications, you have to ask the patient what are they taking and who prescribed or which institution prescribed the medication. There is medication prescribed by a friend I got from a friend who was taking similar medicine. Those are unreliable. But it must be medicine they got after being properly examined at a health center. Okay. But if you are my relative, no, I have a relative who is a doctor, he gave me this. The other people are likely to believe that I gave you the correct medicine. But there are also cases of people that we don't know. Social history. Alcohol intake may cause toxic or nutritional optic neuropathy. Optic neuropathy, allergies, especially to any drug that may be used in the treatment of glaucoma. This is more common in Europe. People they are so particular about the drugs. But you will find here in Africa, here in Zambia, although things are slowly changing, the majority, they won't tell you. They won't tell you. Slowly things are slowly changing, but since I started medicine, these are difficult areas to get from a patient who has come, say, from Karingaringa or something like that. Now there are a lot of educated people there. Those good old days, yeah, it's a big problem. Examination of the patient. You've taken the history, you examine the patient, visual act likely to be normal except in advanced disease. Okay. Pupil reactions exclude the relative afferent pupillary defect. How would you exclude? This is for the two of you. A relative afferent pupillary defect, how would you exclude it? How does it appear, the relative afferent pupillary defect?
Like when you shine light to the one eye, or the normal eye, or the damaged eye, the other one will constrict instead of, I mean, will dilate instead of constricting.
Why? You haven't shown the torch in the.
I mean, when you shine torch.
You shine first. Okay, let's start proper. Let me hear proper. You shine in the right eye. What are you going to see?
Yes. Instead of.
No, first in the right eye there. What are you going to see?
Normal reaction is supposed to be to constrict.
Okay.
Yes.
I go to the other eye. What are you going to see?
You are still shining the light in the right eye. Yes. It also it's supposed to constrict as well.
Yes. I come back again.
Constricting. Supposed to constrict again.
I go back there.
Same.
Constricting.
Yes.
While I'm swinging here, and this one instead of now constricting, it's dilating.
Yes, that's where now.
Why does it dilate? What is the meaning of that dilation?
There should be pathology.
Which pathology?
Optic.
Which pathology?
There's a
Where? Where is the relative damage?
Within the or between the optic nerve to the optic tract.
No.
To the,
Where is the, in which eye is the damage?
the same eye you are shining light and direct.
Okay. The same eye I'm shining the torch in and it is directing.
Yes.
There is what? Damage?
Yes.
Where?
Between the optic nerve or optic disc
Mm-hmm.
to the optic chiasm.
Mm-hmm.
Yes. That's where the damage is. The damage is.
That's where the damage is.
Yes.
Okay. Why?
Okay. It can be due to maybe the same raised intraocular pressure.
Look, you started very well. Relative RAPD, afferent pupillary defect, isn't it? When you shine a torch here, the light goes in. The normal reaction is for the pupil to constrict. If I go there, it will constrict. I come here, it's constricting. That's normal. Now, if there is a slight damage here of the two eyes, there is slight damage here. As I swing there, it's constricting. When I come here, it is still dilating because of the relative damage. It's the afferent fibers which will receive the light, isn't it? So if those are damaged, then there isn't enough fibers to take that light perception backward. You call it relative afferent pupillary defect. Afferent going in, efferent coming out. The constriction is the efferent effect. So, if you have partial damage in one optic nerve than the other, that's the only time you get RAPD in this eye, which is partially damaged. If it is completely damaged, there will be no reaction because there is no afferent whatsoever. If there is a partial, that's where you have that. Because a torch there means constrict. I come here, a torch here, constrict in a normal. If there is damage here, the constriction won't be there. Constriction will come because of perception first, then in the efferent part follows. Anyway, let's not get out of this one here. You've done the visual acuity, both eyes individually. You've done the pupillary reaction, exclude the relative afferent pupillary defect. Color vision assessment, you can use the Shihara test charts. Then you go on the slit lamp examination to exclude features suggesting of secondary glaucomas like pigmentary or pseudoexfoliative material on the pupillary. Check intraocular pressure and note time of the day. Why are we noting time of the day? Because, yes.
Open angle glaucoma. Sometimes it can present the size you want, or at that particular time, or it cannot present the same signs we are looking at.
No, it's not always that you are going to have the same pressure in 24 hours. Like a stuck needle of a watch. No. There's variations, you know. Welcome. No. Why? Why should I masura you chap? Oh. Unabufwayo ovumi vaichemwe. Maiche. Mutende. Mulishati. Chawama. So this has to be done. Ngamachaya pressure, vision, pupil reactions. You know, you look at when you're on the slit lamp, you have to start looking first at the red margins, evidence of any blepharitis. You know, you find the white stuff stuck on the lid margin in your lashes, both the lower and the upper. Then you go on to the conjunctiva. You have to retract the lower lid to see and the upper. Then you go on to the cornea. Is it clear? When you look at the conjunctiva, you are ruling out conjunctivitis, inflamed conjunctiva outside. Then you go on to the cornea clear, you're able to see inside the eye. If you're able to see inside the eye, you even see the pupil. When you shine a light there, it is constricting. That's normal. Then you go to the lens. Is it clear? Clarity of the lens, what is important is the center of it. If there is an opacity peripheral, it will not affect someone's vision. It's where the pupil is, where the rays pass through. To see the back of the eye we're talking after the lens, you have to dilate the pupil. You may have to dilate today one eye, tomorrow another eye. So I think person is so I have don't dilate full blast. The patient vision will be very poor. Unless you know, if they are driving, they will not drive properly. They can't drive with the dilated pupils. So those are the things you ask them. Is someone driving you? Are you driving on your own? No, come with someone who can drive you home. You don't want to push that person to go and die by himself. This disc examination, you really have to direct the pupil. Look at the disc. You are trying to see if there is capping. Okay, cap disc ratio is the diameter of the cap, which is normally in the center, and over the diameter of to the diameter of the disc itself. That's what is called the cap disc ratio. Record. You've done the pupillary reactions. There is pupillary reaction or there is no pupillary reaction. If there's completely no pupillary reaction, when you direct, the pupil is not constricting, that's a blind eye. That's a blind eye. Okay. When you shine there, this will constrict. When you shine directly, it doesn't constrict. It's a blind eye. The issue is you don't just say, no, people not constricting, it's blind eye. You have to go further to examine the actual posterior segment. Look at the retina. Why is the patient not seeing? Look at the disc. Is it completely damaged? Cap disc ratio 0.9, it means it's completely damaged, severe glaucoma. Okay, very important. This importance is unless you do it on every patient. Management. The aim is to prevent functional impairment of vision within the patient's lifetime, slowing the rate of ganglion cell loss by lowering the intraocular pressure. MNM for treating the glaucoma. If you lower the pressure, you are delaying ganglion cell loss, which normally occurs because of the pressure. Okay? Hoping the patient can have many more days of a bit of vision. This pressure, once you lower it, just to be maintained in the lower range. Lowering while you leave it to fluctuate is not a good idea at all. You are not achieving anything. What is that? Too late. Prevent functional impairment, yes. Patient's instruction: explain clearly the following points to the patient: the nature of the disease and the fact that this disease is lifetime. So the lifetime status must be known from the word go, because if you don't, some patients are impatient. Because she started medication with a poor concept. You didn't explain that if we stop giving you medication, you're going to go blind.
Morning, Doc.
Good morning, ma'am.
How are you, Doc?
Well, surviving one day at a time.
Yes, Doctor.
The Lord has offered today at least.
Yes. You are okay? I'm okay.
So the patient should know the concept. Otherwise, a lot of patients go there. Eh? Ngata which to explain parapene, you've missed. That chap will just disappear. So you are going to explain these are diseases for life. Every day. So that we maintain your vision. Ngamwaleka mukapofula. Malikwata bakumikuwa bakumikulika nshakwa apope napo mwishibe musalepo amana. The chap will be extrajudicious. Utumuti twati tauleta kuno. Aishu atinala kufuna. Nobanga taulandile. There's always that tendency. The patient who jahana when atendwa ma. Apo nandi. Anandi bala pola ilomba ine. Especially bale ya kuklimiti ingo. Bale pola baba keratitis ya pola then. Enatina nomba mukese next week. Unless from the way you go, you tell them what is in it. If you fail to do that, you've done a disservice to the patient. They'll just disappear. So explain clearly the following points to the patient: the nature of the disease, that is lifetime status. Control. Offer explanatory booklet if available. Timing of medications. Educate on eye drop installation. Need for follow-up visits. So at tule mona progress mule pangana nguyo mule missing ako. Possible or potential side effects of the drugs being used, and the possibility of early blindness with non-compliance. You should explain to them. Metamuposele kwa mano shukuru mukapofula. But until you explain, that's when they'll be serious. And the opportunity is that time when you are trying to give them medication. You have to explain all the points which are there. Otherwise, they will take things casual. And if that person gets blind within a year, you are to blame also. You didn't warn them. Because if you warn a patient that they are so strict that na review mule isatule munefyo muchitire. They will come. Banje batinga nareko yomuti napofula. Ngangaya chakwatana wakunkulika. So these are very important things as you interact with the patient. And the point is, you see, glaucoma, takwaba pain. Where a disease where there is pain, don't worry, the patient will come because pain yachiramu. This one is painless. Vision going slowly. So unless you emphasize these points to the patient, by the time they come to realize that it's important to take every day to go to review and the road, it's too late. They're already blind, maybe. So from the way to go, let's be serious. So especially Chikalamba, nangu mwana wavo valeta uyati mwamona ngata mwalemu leta fikachitika ndifinei alapo mukakwanisha uyu mpaka akave 50 years no one can manage that. Nishvalamba nomba vakukubika. Life becomes very, very difficult for everyone, the patient and the relatives. They can't do normal things. Okay? So possibility of early blindness with non-compliance on medication should be clearly told to the patient so that there are no surprises. Especially the patient my relatives. You are talking to them by a relative married, if you are married normally, madam wenu, like that. Then you tell them these are facts they must know. Okay, eventually, with compliance, you tend to delay your going blind for a longer period than within 6 months at our number. Treatment goals. In glaucoma, you first set a target pressure below pre-treatment pressure, which is assumed is the pressure causing the damage to the eye. So nakwata muntu aisa say nakwata 18 millimeters. Obviously, you want to set a pressure below that, isn't it? You assume this is the pressure where he's got this problem. Okay, let's say tukayako 12. You go slowly. It's not it's not done overnight like that. As they come for review, you keep checking. Maintaining pressure. It's not bad. There's no way you push it further to 1 or 2. So it's okay. And there is no other medicine. Okay, you can try trabeculectomy to improve the flow and the lot. So target pressure below pre-treatment. Pre-treatment, it means the pressure you assume is the one causing the damage. So you want to set a target below innovation. You go down and see afterwards whether it is changing. When you set that target, they will be on medication. On medication, they come, you check the pressure against last time. Is it rising? Is it same? Like that. It's a big job, but it has to be if you have to save someone from blindness. If intraocular pressure is not controlled, other options should be considered easy surgery. Primary open angle glaucoma. Control. Try to do a trabeculectomy, surgical means, to allow the pressure the drainage to continue. So you offer them that trabeculectomy. Then they continue also, because you've offered that, it doesn't mean they will stop medication. You have 2 now options trying to reduce the pressure. Okay. Proportional reduction of intraocular pressure. Alternative strategies to aim for intraocular pressure reductions of 30% and then monitor. Further targets are later set for further intraocular pressure reductions if needed. This is a good concept. You've given yourself a target, 30%. Ngayakwa na 30%. Mayapanga visual fields, you check whether he has lost a lot of visual fields or the visual fields are stable. Visual fields must be stable, it means he's not losing. Not what ulemona. Obvious central vision is still okay. It's the peripheral field. So you only check pressure and visual fields. Visual fields, you and the patient won't know at the constrict. So when the pressure looks to be okay within normal, normal, we're taking our readings, I can't manipulate our readings. But you catch them, go and do visual fields. You check with the previous one, it's different. It's worse maybe than the previous one. Why should it's cheating here? It's cheating. For what? I don't know. But the patients are like that. They also get fed up sometimes. So monitoring of optic nerve and visual fields, in the event of further damage to visual fields, one resets a lower intraocular pressure. If you do the visual fields, you find there is still damage. It means the pressure you set as a target is still higher. You have to set a lower target now. No, I tackle reduce, then continue again. After maybe 1, 2, 3 months, you come and do the visual fields and check with what they were doing. The best visual field is you are aiming for the visual field to be stable, not to be changing. Okay. This is a difficult part, but necessary if you want to keep someone, with the sight. No.
She's listening.
Huh?
I don't.
Okay. Medical treatment, commencing medical therapy, any chosen drug should be used in its lowest concentration and consistent with the desired therapeutic effects. Ideally, a drug with the fewest potential side effects should be used. Initial treatment is usually with one drug each year, a prostaglandin or a beta blocker. You get one drug, see how they are going. Don't start polypharmacy. At a later stage, it becomes difficult to notice the side effects. It's important they are taking medication. It's important you are also checking the pressures. Review, interval to review after starting medication, you set according to individual patient. Some patients have other things they want to do. They can't commit themselves just for 1 month. 4 weeks to 8 weeks is okay. But initially I would put it that even 2 weeks for 1 month or for 2 months, for 2 weeks, 2 weeks, 2 weeks, you see how they are controlling their pressure. And now more 1 month, 1 month, 1 month, 1 month. Give them another 1 year also. Like that, Response satisfactory, subsequent review is set at a higher period, If the pressures are not satisfactory, you reduce that gap they are spending away. Incomplete response, it means it needs another drug to be added so that there is proper drug effect. Okay. That's how it goes. Poor compliance and inadequate drop installation should be considered as possible causes of unsatisfactory response, especially in the elderly. There are some elderly patients, they don't have, they have relatives. They even stay with relatives. They hardly even bother to go and tell him. So now no medication. So you have to look at all this. The other important point is perimetry, visual fields. You must do them at least I think twice or once a month is okay. Perimetry. Perimetry gives you genuine picture of what is happening there. Whether it's losing vision, because there's central vision, but meanwhile it's busy losing the peripheral vision. That's not good enough. So every 2 months, you panga kama visual fields. Maisha compare na ya kale, whether they are constricting or they are remaining stable. If they are remaining stable, it means you are gaining something in the treatment of that patient. If they are constricting, you are not working, it's no good job. Any questions? Questions. Questions, ladies and gentlemen. Or they're still thinking of the questions. But it's important. This is a very common condition in Zambia, glaucoma. Whereas in European countries, tukotenga na tuisa solo, and yet it can be controlled. It can be controlled. You know, once you control, you know, an old man who is seeing is less of a bother to you than an old man who is not seeing. Because we can't tell kwa menshi, can't tell kwa fi. Napa kuyo wali pose, ni peso munanuli. You know, you can avoid all those things by being kind to him, so that he continues to take medication and doesn't end up blind.
Good morning, sir. Good morning, doctor.
Good morning. Pule. Oh, this is the one.
Okay. Is there a physical visual fields?
Sorry, say again.
Is there a physical way of examining visual fields other than using a device?
I think yes, you can, you know, but the one which is more consistent is the one where you use a device, because it traces and a proper picture comes out. The one where you're using your fingers coming from the periphery towards the center does give you something, but it's not consistent, you know. There are machines, visual field, which do visual fields. I think it's better a patient like this who is on long-term treatment, who is on long-term to have visual fields, they go to a proper machine, to a proper eye clinic, and they do the visual fields when needed. Usually it's once a month they do that. Okay. Bom dia. Anyone else? Karen.
Good morning, doctor.
Good morning, mommy.
I wanted to ask on the tonometry,
Yes.
the applanation tonometry. You said that whether you are an ophthalmologist, whether optometrist, we also have to learn it. Do we have this instrument in Zambia?
Where is the instrument?
And
in Zambia, yes, we have applanation.
When we will have a chance to learn about it during
Yes.
our clinical skills.
Yes, you will.
Okay, thank you.
Thank you, mommy. Oh, you see, when I say tonometry, there's no, it's there, you're going to learn. And when you go out there, you're optometrist. But wherever you're going to go, you'll be working in the eye clinic. You'll be part of the eye clinic. The doctors will be very happy. Ah, this one, refraction, go to room so. They know there's someone who can do a quick refraction. Next question. Chapo. Questions, ladies and gentlemen, so that we clear the issues here. Glaucoma is a very, very, very important topic. It's a common disease. It's a common disease.
Good morning, sir.
Good morning, Mommy.
I have a question. What is exoplasmic flow?
What is it?
Exoplasmic flow.
Do you know the spelling of what you're saying?
Yes.
What is the exoplasmic flow?
Exoplasmic.
What is it?
This one.
Which one?
Exoplasmic flow.
Oh, exoplasmic flow.
Yes.
Lead to reduction in. You see, you've got nerves, nerve fibers. Within the nerve fibers, in the center there is what is called, it's like the plasma within there. So if you do compression, there will be reduction of movement of those exoplasmic flow. And the compression there will ultimately lead to the death of the nerve fibers. So reduction of exoplasmic flow leads to death of these fibers. Damage is via both mechanisms might lead to reduction in, I think before this slide, we've got another slide. We're talking of ischemic damage possibly due to compression of blood vessels supplying the optic nerve, as well as damage to the exoplasmic flow. The nerve fibers are also compressed. So it's both compression of the nerve fibers within the eye and also the vessels, which ultimately leads to the damage. So when we say of exoplasmic flow, is that compression which occurs leading to damage of these nerve fibers. While compression on the blood vessels will lead also to reduction of blood flow to the area where they supply. Okay, Mommy?
Okay.
Thanks.
Thank you, sir.
Thank you very much. Yeah, so compression doesn't end up just for vessels. Even on the nerve fibers there, nerve tissues. Once you sorry, another question? Rosira.
Yes, sir. Doctor, I wanted to ask about the applanation tonometry.
Yes,
You mentioned that it's used to flatten the cornea.
Yes.
The applanation tonometry, you mentioned it's used to flatten the cornea. So is this flattening permanent? Like once they flatten it once, Will it remain flat just like that?
No, firstly, the flattening is not permanent.
Or does it?
What you have is a cornea, which is more. What you have is a cornea which is more like an eyeball. I don't know if you can see what I'm trying to draw. This is cornea. I will show you just now. Like that. Okay. This is the applanation head. Are you able to see? Or this one?
Yes.
Able to see this one, isn't it? Is she able to see the
Yes.
picture? This is the applanation tonometer. If you look at the head here, the white part on the this is the one they are showing here going up. And this is an eye here. When you press this applanation head onto the cornea, it displaces the tear film which is in front of the cornea. And because this head is in two parts, that circle you're supposed to see is broken into half circles. And to make the end point, the inner side, here are the half circles. When you touch the cornea, what you are seeing in the picture are half circles. The aim is to have the inner part of this semicircle and the inner part of the upper semicircle touching to each other. That's the end point. At that point, you are able to read what is the pressure reading in the eye. Are you with me?
Okay.
So this head, you'll be looking through this head. As it touches the eye, it displaces the tear film in front of the eyeball into semicircles. For example, this one is the best there. Now, your aim to reach the end point is the upper and lower part. The inner sides must touch. You are not aligning them head on like that. You are just, what you want is the inner part of the upper semicircle and the inner part of the lower semicircle. Just those two parts touching. That's the end point at which you read what is the pressure in the eye. Now, to do this thing, obviously, you have to give some anesthetic because you're going to touch the eye. Any touch on the eye, the patient will not be comfortable. So you have to add before you even put an anesthetic. You also put the dye, fluorescent dye. Then that's when you go to the to try and displace that fluid which is in front. Yes.
So where do you view these sequence?
You
thank you, doctor.
Thank you, Mami. Thank you. And you who is controlling how far you can go forward and back, because you are seeing the semicircles. When they touch, that's the end point. Then you read what is the reading. I think this is best demonstrated in the clinic. It's demonstrated so that people know how to take proper IOP. Any other question from somewhere? Those are children, yes. Helping the mother to learn. Questions, ladies and gentlemen, questions? Clear, isn't it? Too close? What about the questions from you here? Well,
If you
yeah,
have a
ask what is the question?
Sir,
Yes, please.
it's just a suggestion.
Yes, what's the suggestion, mommy?
Wouldn't it be best if we were to have booklets at our clinic explaining on glaucoma so that we can be giving to patients?
more like brochures.
Brochures, yes, it would be
Yes.
nice. What you're suggesting is there in some other clinics somewhere else? Our clinic is, I think, with the integration with the Levi Mwanawasa Medical University and the hospital, it should be possible to do what you're suggesting, because a lot of centers, it's better someone goes with a booklet. They may
Yes.
not read, but they will have someone who can read for them and explain what it is. I agree with you.
Not only booklets, even posters, maybe in the clinic where they are stuck on the wall. Then when patients come, they're able to see the posters on the wall.
Yes, we're supposed to have that. Other clinics which have been functioning for a long time, they do have all those things you are suggesting, ma'am.
Oh,
Maybe we're still young in terms of development here. But I think we're in the right, we are on the right path. With time, sooner than later, things should be able to straighten up. It's a question of putting all these things in the clinic. I'm confident there will be something like that sooner than later. Any other question, mommy? Suggestion?
no.
Thank you very much.
Doctor, I have a question.
Yes, please, mama.
You mentioned to say primary means that there's no apparent cause. But then again, we've learned that myopia is one of the risk factors as well as diabetic mellitus. Doesn't that mean that those are apparent causes?
No, when I say myopia, myopia itself does not cause glaucoma. We're talking of glaucoma here, isn't it? There are a lot of myopic people who are not
Yes.
glaucomatous. But there are glaucomatous people, some of them who are myopic. It's not a direct cause. It doesn't mean when you are myopic, then you must have glaucoma. No. Me, I'm myopic, but I don't have glaucoma. I have other diseases for old age. No, it's not in every patient, mommy. But the idea of posters, I think it would be good for the patient. It's always good for the patient. When you're explaining, at least they can see. I'll talk to Professor Mumba to see what you can do. But first I have to see where the clinic is. You know, to suggest these things. I've not even been invited to see the clinic. This one at 11. Is at for glaucoma. Okay.
And for this one, everyone.
This one is a teaching clinic actually.
Yes.
The way it was opened, it was not part. I had to literally push myself to them and look, you open it. When we opened it, it became so popular. Now it was difficult to close it. I don't want it closed myself. As far as I'm concerned, this is a clinic which helps patients.
Yeah, people can see.
Now everyone around here, they know you go to China, there is an eye clinic. And I think we're doing a better job than these people going to these other clinics, general clinics. They're not managed properly. They are better off here. That is time. Eventually, when you people graduate, wherever you'll be managing properly.
Yes, Doctor.
That's the whole idea. This one had to quarrel with the members of staff. Not here. Could have go central division. Look, that place. Let's see. No, first where the clinic could have main entrance, they came and broke it up. It was sponsored by site savers. So I told them, look, let's shift. Let's have a block of one block there. You want a clinic so that patients can be seen here. Yeah. It took time to convince them. Once they got convinced, every time they come, they see their patients. Next time, but why are you coming here? You, where you are coming from, there is a clinic at no. I want to hear. Because they were being treated well. Yes. They are being treated. The patient is, everyone is human. They want to be treated with respect. The fact that they are sick doesn't mean now it's an opportunity to push them around, And that's patient they know. The people come here are not even, not all of them are local. Some are coming from very far. So we'd like to continue at that pace. We're done, isn't it? No other questions? You have a question?
Oh, it's written. Yeah, it's a form of message.
What is the question?
The question is between open angle glaucoma and closed angle glaucoma. Which one causes more damage to the X-ray? That's the question.
All of them do cause damage. Who is asking? Is on the. Is from where? From where the question? Open angle and close the angle.
Yes.
All of them they cause damage. The aim should be to control the pressure to come down within the normal limits. As far as because it's a lifetime treatment. There's nothing like because you've controlled to the normal limits, then you can stop. That's the concept patients must understand, that there is no stopping. Once you stop, you are allowing the pressure to rise again. Once the pressure rises, it's more damage onto the optic nerve.
So once the optic, some part of optic nerve is damaged, you cannot reverse it.
No, you cannot reverse it.
It's permanent.
It's permanent, yes. That's why you should aim at not damaging you. Once you control, you have to keep controlling. There's nothing like, oh, now we've controlled, forget about it. No. Immediately you forget about managing that patient, the pressure will spike and they'll be blind. This is a lifetime treatment. It's not like now I've reached the end point, that's it. No. You have to continue ensuring that, and the patient must understand. When they take one reading, it's a nice reading. The pressure will build up and again more damage on your optic nerve until you go blind. Pressure gives you that chance to see. Okay. No, there's nothing like you have been controlled, you are discharged from.
You have been controlled.
And a question, doctor.
Yes, Mami.
So does that mean that even the surgical treatment is not effective because you said that this is a permanent condition? So what's the purpose of the surgical treatment?
Surgical treatment has got better outcomes. But once you do the surgical treatment, you lower the pressure. The monitoring must continue. Yes, it's better treatment. The pressure comes down, but you have to continue routine monitoring so that there is no rise of pressure. Because once you miss that and the pressure rises up, there are a lot of things which can again lead to pressure rising. What is trabeculectomy? They're giving a valve, you know, a space where fluid can come out into the sub what? You have a flap. The fluid goes under the flap and disperses. That lowers the pressure. Okay. But you have to monitor that it's functioning. The trabeculectomy is functioning. It can fibrose and stop functioning. So you cannot assure the patient that this is now permanent treatment. It's good treatment, but it must be followed by routine reviews. Even once a year or twice a year is good enough. You know? What you can't do is to discharge them and tell them, I know Manam Pola complete. The time the patient will come back, they'll be blind in that time. Okay. Does that answer your question, Mami, there? She's not there.
Okay, there are questions from Benedict. And two.
Okay.
Yes, it does.
Okay, thank you, ma'am.
Saying, may you demonstrate how we check visual field physically? Then another one is, why do we add the dye as well?
A dye where?
In the applanation.
Applanation tonometry. Okay. You see, if there is no dye, you will not see the sake of, you know, the fluids. It is colorless, it is. Tears and fluid, the water, all they are all colorless. So it's deliberately colored so that you can see the color of where the film is. Without that, you won't see it. It will be ordinary water. Another question? There is?
Oh no, maybe just this one. How do we demonstrate? How do we check visual field physically?
Okay. Well, the patient is looking at you. They will focus at someone. Then and your finger must be coming from there. You're also looking at the patient. The patient is looking at you. You bring a finger out there. Me, I can see it from there. That's the patient if they can see. This is roughly from top, from there, from bottom. And it's the same principle when you go on the visual field machine. Things will be coming, then they will, once you see it, you press the button. It's taken that you've seen that. And those are the points which are used to the field that you have got. How's the time? 11.
It's 12:06 now.
Questions?
Yes, doctor, I have a question.
Yes, Mami.
Hello?
Hello, shoot, Mama, shoot. Hello. Let's have the question, Mami.
Oh, yes. I wanted to ask about the open angle glaucoma, knowing that it has no apparent symptoms that the patient will experience. Their central vision will be okay. There won't be any pain. What brings them to the clinic or what can help the ophthalmologist or optometrist to fish them out? Does it mean we need to check the pressure of each patient that comes in, since there might be people in the community who are asymptomatic?
How do we catch these patients? It's difficult. Yeah, the question is a difficult one. But whenever a patient comes for their routine checkup in the clinic, it's better we do some visual field, or routinely once a year you come and they have a visual fields done. Except it's not practice here. Where I trained in UK is like standard. You can go and have a visual field. My relatives went blind and I always have my visual field once a year. And they go. And the problem with these visual fields, the central vision usually is the last one to go. You've lost all this because you are able to see directly central vision. You think you don't have a problem. By the time they come to realize they have a problem, a lot of visual fields have been lost. It's the routine checkup, the history in the family. Someone has got this history of visual field loss of vision. You should also go for a checkup. Just go and they do a checkup for you. Once a year, it's not a lot. It's not a lot. But whether we'll reach that stage, I don't know. In the villages, they need a free checkup. They will not manage to pay. In the villages, they need a free checkup.
Another question.
Thank you, doctor.
Thank you, Mami. Sorry, I'm looking at another question here.
Is it possible, especially on medical treatment, to change on a type of medication from one prostaglandin to another, or from one beta blocker to another, due to circumstances?
What circumstances? I would like to know what circumstances. You see, the circumstances which he's talking about, which she hasn't told us.
Maybe the patient.
Maybe
the patient is not compliant with that medication.
Or maybe they are allergic to one.
Yes, naturally. All medication, if you start someone and they're allergic, you have to change. But that's a question which is resolved as the patient comes for the routine checkup. If they have a problem with the medication they are taking, they're supposed to say it to the patient, to the doctor. I'm uncomfortable with this for 1, 2, 3 reasons. Then the doctor will see which way to go. Do I change? Or maybe it's not, there's no need to change. It's because maybe the dosage is slightly higher. You reduce a bit. Those are issues patient doctor can discuss on a review. And the patient, I'm sure, will appropriately react. There is no one solution for everyone. You first ask, you look at what the patient is taking. Is this on the higher side or not? Is this on the lower side or not? Then you make up a decision of what you're going to do, whether to change, because some people are uncomfortable with this drug or they can't make it. Sometimes they are buying their own drug. It's not that they are collecting for free. No, I can't afford. You give them something cheaper.
Okay, she's given the specificity, saying maybe due to the circumstances, the absence of the previous medication from any nearby stocks. Is it possible for you to change? Like if they're all beta blockers,
yes,
then you'll find there is no the specific one you use. Then is it possible to switch to the to another one, but in the same group.
But why are you switching? That's the reason I want to know. Switching is not a big deal, but it's a question of what is the basis for switching? Is it not doing a proper job? Because those are the reasons you should convince your doctor. If those reasons are not nicely explained, you will be wondering, why are we changing? Even in your notes, when you write patient uncomfortable with this because of this change, try this drug. It makes sense. Rather than this patient is on this treatment, then suddenly there is a note, change to this. There must be a basis when you are changing. The patient is uncomfortable. The drug can't be found when she goes to buy wherever she stays, like that. Those are the things which the doctor is more likely to agree to. Try this one. If that one is not available in your local shops, try this one. But if the drug she's taking and is maintaining a good pressure, there's no need to change it. Unless there are those things, side effects, no, I'm not comfortable, I'm not sleeping well, or something like that. That's the basis for changing drug. Any other questions? Oh, we go and we relax now. Yeah, point.
You can no longer ask him.
Okay. Chungulo Mairo.
Right.
Yeah, I think we can come and have one more. Morning. Why afternoon? Eh? Afternoon, we have other things to look at, young man. We can come same 9 o'clock. We'll look at what lecture. There are enough. There are a lot of lectures you have to learn. We'll sit and look at which one you can handle my.